Please start, sir. We are live.
Hello, good evening, everyone. It's a pleasure to welcome you all for this very wonderful webinar on metastatic breast cancer management. It's a pleasure to welcome and invite our convener, Dr. Chandragowda sir, who is Associate Director, Medical Oncology at the prestigious BLK Super Specialty Hospital, New Delhi. Once again, a great good evening to everyone. The Delhi is absolutely pleasant, so good evening, and Dr. Chandragowda sir, over to you. We look forward for your welcome and introduction and opening remarks. Over to you, sir.
Thank you, Tarunji. Thank you, Healthy Blossom, for arranging such a wonderful conference on metastatic breast cancer. So thank you all speakers for making it for today evening. And it's about we are talking on three topics in the metastatic scenario: VR positive, HER2 positive segment, and HER2 low segment, and then and TNBCs. So to set the ball rolling without wasting much time, I would like to invite first speaker, Dr. Noah Gupta. He's a great speaker, a great colleague of ours, and he's a consultant medical oncologist at Jindal Hospital, Palwal, and he'll be speaking on low HER2 breast cancer. Are we searching for a new for searching a new indication, or understanding God better? A very interesting and topic which probably needs more of the talking in the future to come. So over to you, Dr. Noah.
Thank you, Chandragowda sir. It's good evening, everyone. It's a pleasure to be here on this platform. So I'll share my screen. So is my screen visible?
Yes, sir.
How does this go off?
Go off. Okay. Please click on ESC button. So please make a full screen.
So press F5. Now use the arrow key, down or right one.
Okay. Anyways, good evening, everyone. I'm Dr. Noah Gupta. I'm a consultant medical oncologist at Jindal Hospital, Palwal. And thank you, organizers, for giving me this opportunity. The topic given to me is low HER2 positive breast cancer. Are we searching for a new indication, or our understanding has got better? So first of all, what is HER2? Something about HER2. HER2 is something we've been, it's absolutely integral when we are treating breast cancers. It was something which was, discovered back in the 1980s by Dr. Solomon. And somewhere around the 2000, the FDA approved the definition of HER2 positive as a tumor cell positivity of 10%, which was labeled as IHC3. Now, this definition of HER2 positivity has been, kind of revised somewhere around every 6 years. In 2006, we changed the IHC3 plus definition of tumor cell positivity of 30% cells or more. But then again, after somewhere again of about 6 years in 2013, we redefined this HER2 positivity of IHC3 plus, going back a decade again with the tumor cell positivity of 10% or more. And then again later, after another 6 years, approximately in 2018, the newer HER2 positivity guidelines have been published. So this is what we'll be talking of, the new HER2 positive guidelines. This is how these tumors which are, have some HER2 positive are evaluated. In case the tumor cell, the biopsy shows with the IHC, which is done initially, shows a complete and intense positivity in more than 10% of the tumor cells. It is labeled as IHC3 plus, and the disease is labeled as a HER2 positive disease. The problem comes when it is a IHC 2 plus. That is when the confusions start to crop up. A reflex ISH testing is done, and if it is positive, then the disease is labeled as a HER2 positive disease. While if the ISH is negative, it is labeled as a HER2 low. Now, the third thing is the HER2 1 plus by IHC, which is usually taken as a HER2 negative disease till now, but now it is labeled as a HER2 low disease. So HER2 low, some of the, I'll say oncologists or institutes, some of the times they also say that with the IHC and also an ISH negative is taken as an HER2 low, or a ISH not done is taken as a HER2 low. This is probably because IHC has, we are all aware that there are a number of times it's objective test, and there are discordant results between different labs or different pathologists. So overall, when we're talking about somewhere about 55 to 60% of the metastatic breast cancer patients do have a HER2 low disease, which is, till now has been treated as a HER2 negative disease. Now, HER2 low is defined as a IHC 1 plus or IHC 2 plus with a negative ISH. The thing is that all these set of patients which are HER2 low, our present anti-HER2 therapies have not been able to show any clinical benefit in these set of patients till now. So overall, at the time of progression, most of the times the treatment is defined either based upon the hormone receptor status, or it is a single agent palliative chemotherapies which are offered to these patients. So these are the results of our present therapies which are available either in the adjuvant setting or in the advanced breast cancers in the set of the patients who had a HER2 low disease. So overall, none of the trials results was positive, be it with trastuzumab or pertuzumab or TDM1. We also recently had the Christine trial where the neoadjuvant TDM1 with pertuzumab was utilized in the patients with a HER2 low or the HER2 heterogeneous set of patient population. And what was seen is that these set of patients had a increased local regional progression with the neoadjuvant therapies. So overall, these therapies have not been effective, is either because of the low addiction of the HER2 or whatever it is. That is what we have been struggling. But I'll just say that there is always light at the end of every dark tunnel. So by 2017 or 2018, we had some good news with the two newer antibody drug conjugates, the ADCs, the trastuzumab deruxtecan and the trastuzumab duocarmazine. The data of the phase 1 was released, and good responses were seen. The trastuzumab deruxtecan, the phase 3 trial, the Destiny Breast 04 is something which we'll be discussing in the coming slides. The trastuzumab duocarmazine, also the TULIP trial has been published, which has shown a PFS benefit of about 3 months. The drug is presently under review by the FDA. So now these are the 3 ADCs which are there with us. The thing is that these 3 are all different molecules, and probably that is the reason why we do have different clinical outcomes of these 3 antibody drug conjugates. So TDM1, we are all aware of. We've used this drug in a number of patients. The SY-D986 is the trastuzumab duocarmazine. I will not be talking about this much. The TDXs or the trastuzumab deruxtecan is something which we'll be discussing today. I'll just broadly tell why is this molecule really interesting and why we are able to get these improved outcomes which we were not able to get with these prior ADCs. So this molecule, this is a cleavable molecule. it's a beautiful pharmacology which happens. The first of all, the payload which is present in the TDX molecule is more than twice what is present in the TDM1 molecule. First, secondly, this is a cleavable molecule, and when the payload breaks off, it kind of has a memory permeability. And I think we have a graph cartoon in the coming slides also. I will talk in that slide. So and the payload also is a topoisomerase 1 inhibitor, which is kind of unique in our breast cancer patients. So that is the reason why we are able to see the diffusible cytotoxicity and the bystander killing effect, because of which even in the patients with HER2 low or heterogeneous positive tumors, we do have a clinical efficacy of this drug. So this is a beautiful cartoon of the difference in the patients who have a HER2 low breast cancers when treated with either TDM1 or a TDX. I'm really sorry. The second one, this one is the TDX molecule, and this is the TDM1 molecule. So the TDM1 is something which would bind, this is a non-cleavable molecule. This would bind with the HER2 positive cells and cause a cell lysis of those molecules. Whereas when the patient is treated with the TDX molecules, so this payload, it goes off, it binds to the HER2 positive cells. Also, the payload gets released, and it acts on these cells which are HER2 negative, which are present in close proximity to the HER2 positive cells. So even if the disease is it's a heterogeneous disease, even in those set of patients, I mean those tumors, it is able to show the cytotoxic effect. Now that was the basic why of this molecule. Now coming to the trial, the Destiny Breast 04, as was a multi-center randomized open label active control phase 3 trial. The patients had received prior 1 to 2 lines of chemotherapy. These patients were randomized in 2:1 fashion to receive either TDX at a dose of 5.4 milligram per kg 3 weekly, or to the ICT or the investigator choice of chemotherapy, which was either capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. The primary endpoint in this was the PFS in the hormone positive population, whereas the secondary endpoint was the PFS in the ITT population, and the overall survival in the hormone population and the ITT population. So now this is the same slide. This is what we have talked about. So, interestingly, again, about 50 to 60% of the patients have a HER2 low breast cancer. This is a huge set of patient population, for which I can say this is an unmet need, a huge unmet need. This the majority of these patients do not have any therapy as of now, and TDX1 is kind of would fill the vacuum in this. So now coming to the baseline characteristics of the patients, there were the median age was about 57 years. 99.5% of the patients were female. There were about 36% of the patients who were Asians. HER2 IHC 1+ was seen in about 60% of the patients, and IHC 2+ with negative FISH was seen in about 40% of the patients. Hormone positivity was seen in about 90% of the patients. Liver mets in about 70% of the patients, and lung mets in about 30% of the patients. So the median lines of therapy which the patients had received systemic therapies was 3 and 1 chemotherapy. CDK inhibitors was, about 75% of the patients had received prior CDK inhibitors. Now coming to the results. So we have the primary endpoint, which was the PFS in the hormone positive results. We can see that the PFS was double, and it was presented by not N. Modi, but Dr. S. Modi, which, the PFS was 10.1 months in the TDX arm as compared to the ICT population or the chemotherapy investigator choice based chemotherapy with a hazard ratio of 0.51. And similarly, the results in the ITT population is almost identical with the PFS of 9.9 months versus 5.1 month, and a hazard ratio of 0.5 again, and a delta of 4.8 month. Coming to the secondary endpoints or the overall survival in the patients with hormone positive disease had a median overall survival of 23.9 months versus 17.5 months, and a hazard ratio of 0.64, delta of 6.4 months. In the ITT population, absolutely identical results with overall survival of 23.4 months versus 16.8 months, and a hazard ratio of 0.64. Again, the delta of 6.6 months. We have the waterfall plots, and we can see the response rates with TDX in the hormone positive was 52.6% and 50% in the patients with hormone negative disease, as compared to just 16% of the patients in the ICT, the control arm.
Dr. Novak, sir, brilliant presentation as always. Last 2-3 minutes to conclude, please.
Okay. I'll just finish it. So we have all the set of the subgroup of patients who benefited with the hazard ratio of 0.5, somewhere about, and so these are the exploratory analysis. So overall survival, the safety, treatment emergent grade 3 side effects were seen in about 50% of the patients. ILD, I'll just say ILD is something which has a black box warning for TDX, and we should be aware of, which was seen in about 12% of the patients. So mechanisms of resistance is probably different, would depend upon whether what kind of proximity and which would decrease the bystander effects, and what different pathways are responsible. Number of different trials which are ongoing. Just one, I think the Belangio is something which is interesting, which is the TNBCs with low hormone positivity, where the TDX1 is being combined with Imfinzi, and eagerly waiting to see such results. So number of other options coming up: the vaccines, the ADCs, the bispecific antibodies. So to conclude, Destiny Breast 04 has shown a PFS of 9.1 versus 5.1 months, and a OS of 23.4 months versus 16.8 months. The benefit has been seen in across all the subgroups, irrespective of the chemotherapies or the CDK use. So yeah, that is something interesting. I would just say, it is like we are going into a space where from 15 to 20% of the HER2 positive patients, we might be coming up with just 15 to 20% of the patients being not candidates for HER2 directed therapies, maybe in the coming times. So interesting times. So thank you.
Thank you, Noah, for the nice presentations. I think definitely this is making a big inroads with a very good response rates and a good PFS. And even in TNBC setting, as I said, the bystander effect really simplifies and explains all that stuff. And we're also running a trial, DB06 at our center. So when I was in Akash, I enrolled 2 patients in that DB06. That's any breast 06 trial in hormone positive HER2 low segments, post CDK4/6 and hormones. I think that's really a wonderful trial. I want to do patients who the Praveen is handling now. One is on capecitabine and another is on TDXD. So TDXD, I think, received 4 cycles, doing well. So I think it's they just has a long the molecule a long way to go, except the ILD, which we need to know how to manage it. Otherwise, it's a good molecule in that section. So any patients whom any of you shortlist in ERPR positive HER2 low segment, and if they progress on CDK4/6, we can send it across to us so that we can enroll in this particular trial. Thank you, Noah, for the insights.
Thank you.
So moving further, I would like to invite, this is sponsored by AstraZeneca, the Dr. A.P. Dubey, who's a senior consultant medical oncologist from Santhanapur, to deliver a talk on current treatment landscape of HER2 negative early breast cancer. Dr. A.P. Dubey, over to you.
Good evening, sir, and thanks organizers and Astra for giving me this opportunity. So I'm sharing my slide set. I hope I'm audible and my slides are visible.
Yes, sir. Very perfect. Your voice is little bit that network issue.
Yeah, okay. Now am I audible clearly?
Yeah. Yes, sir.
Okay. Okay. So this is the agenda. These are the subheadings under which I'll be speaking in next 15 to 20 minutes. So as we all are aware that breast cancer is the most commonly diagnosed cancer in males as well as in our country. Around near about 2 lakhs of new cases are diagnosed every year, and which account for around 35% of all the newly diagnosed malignancy. So quite a common malignancy if we talk about the cancers as a whole. And the thing which has to be bothering us is that around 70% of the patients will have either loco-regional, locally advanced or advanced breast cancer, and only 30% of the patients will have an early stage breast cancer. Whereas this population is
I think we lost the connection.
Right, sir.
Yeah.
Do we have slides on backup?
No, sir.
I think if it's going to take time.
sorry, sir.
Yeah, okay.
Sorry for the network glitch. And I'm again on the slide where I left. So
You can switch off the
what is
video.
the current treatment pathway for HER2 negative early breast cancer?
You can
So
switch off the
all the
video.
early
Just
breast
speak on.
cancer patients. Okay.
Yeah, that way
Yeah,
it will become better. Yeah.
So guidelines about the treatment of early breast cancer is either upfront surgery but in very few cases where the patient is either triple negative or HER2 positive breast cancer, their patients are recommended to undergo neoadjuvant therapy first, because we have priced individualized treatment for such patients which have increased or which have improved the outcomes in such patients with HER2 positive or triple negative breast disease. So this is the treatment algorithm of the patient with high risk early breast cancer, triple negative. The patient undergoes neoadjuvant chemotherapy, which is the most suited guideline as of now. Or the patient undergoes surgery and receives chemotherapy based on the tumor size, if it is more than 0.5 centimeter or node positive. If the patient is high risk early breast cancer, HER2
Lost him again.
Yes, sir. Very less network range.
Okay. So
It आप सर से उनका पीपीटी ले लो, उनको बोलो हम अपने साइड से चला देंगे.
Sure.
Sir, sorry, sir, there is some network problem.
AP sir, can you please share your slides?
फोन भी नहीं उठा रहे हैं सर अभी वेबिनार में
Okay.
इसलिए.
Now, can I start now?
Sir, if you want, you can share your slide to me in WhatsApp. मैं आपकी slide share कर देता हूँ. आप सिर्फ speak दे दीजिए.
Okay. Presently, am I audible?
Yeah, you're audible. JP.
Yes, sir.
So I'll. So in the patient with the hormone receptor positive, hormone negative, either patient receives upfront chemo, plus minus endocrine therapy, or just endocrine therapy in patients in a special group of patients, followed by surgery, or patient can undergo upfront surgery and later, based on the tumor size or the lymph node positivity, patient receives the adjuvant chemotherapy. Yes, the patient with T2 disease or patient with 1 to 3 lymph node positive, they should undergo 21 recurrence score. So there are recent few changes in the early breast cancer treatment, and that is, one is the introduction of immunotherapy, that the patients who are high risk of recurrence triple negative breast cancer should receive, along with the pre-operative or neoadjuvant chemotherapy, they should receive immunotherapy followed by surgery, followed by single agent immunotherapy. And also the olaparib is being considered as an adjuvant treatment for germline breast.
Oh, we're losing him again and again. I think, shall you proceed to next talk?
Sure, sir, as you say.
I think it's like the third time, got disconnected. Whenever he has connections not set right.
Sir, I'm so sorry, sir. There's some network problem and it's again and again dropping.
Yeah.
Sir, shall I start now?
Yeah, go ahead. Continue, sir. Yeah.
Yeah. So we all are aware that BRCA mutated breast cancer, aggressive disease, patients come at young age and they have very high incidence of recurrence or even the second primary or the contralateral breast cancer. And so the germline BRCA status can have surgical implication that as a patient can be offered bilateral mastectomy, because these patients are having higher incidence for the second primary or the contralateral breast cancer. And also these patients are the one who have to be offered, as per the newer recommendation, can be offered adjuvant olaparib, which has improved outcomes. And also knowing the germline BRCA mutated status also help us for risk stratification and family counseling. So BRCA mutation have been identified in approximately around 1/3 of the breast cancer patient, more so in triple negative population. And in early breast cancer setting, upfront knowledge of BRCA does help us taking many informed decisions. And so it is much recommended that it has to be known before the surgery, so that patient can be taken an informed decision about the bilateral mastectomy, and also to plan the further adjuvant therapy with olaparib. What are the criteria for BRCA testing? Any patient with breast cancer less than 45 years of age, or any patient with breast cancer less than 50 years of age with a family history, or in more than 50 years of the age with family history or personal history. But the triple negative breast cancer patient with at any age should be considered testing for germline BRCA1, BRCA2, and also patient with male breast cancer, and also with metastatic breast cancer patients. And
Uh-huh. I think we can move on to Dr. Piyush so that we can correct his, network and come back again. Piyush, show there?
Yeah, hi.
Yeah, Piyush, I think I wish
Yeah.
technical team, please, you can just talk to Dr. Dubey so that he can come back later. So the Piyush is a friend of mine, and he's heading the department at Manipal Hospital. He'll be speaking on Crixana.
Okay, I'll just call you back. I'll just call you back.
Getting a real with the ribociclib, bridging the randomized control trial with real world evidence. Over to you, Dr. Piyush.
Thanks, Dr. Chandra. And I hope my slide is visible there.
Yes,
Yes,
sir,
it
very
is.
much.
Okay, so these are through Novartis, and thanks to them for these slides. Well, this is about the real world evidence that the drug we are using, ribociclib, and we're getting confident on it with each passing day. And I'm presenting a couple of studies over here, which is actually a collection of basically nearly 8,000 patients. And this is big data, basically, when we talk about real world evidence. So we know that overall survival has been achieved by this particular drug. And this has been one of the parameters which, when as oncologists we speak with more conviction to our patients. And this is why, this is achieving a ESMO MCBS score, a high score over there as well. So definitely overall survival is an important aspect. And whether this is converting or being seen over there in, in the real world, yes, we are seeing patients having a good PFS, a good survival. This is just a comparative chart of the various trials of the 3 CDK4/6, where palbociclib just fell short of achieving this particular benchmark. But nonetheless, it's always important to say that cross-trial comparison is never fair. Abemaciclib has achieved it in Monarch 2 over there, and the Monarch 3 trial, the results are pending, but you have the 3 green ticks over here in the ribociclib box, and that's all overall survival data being presented and significantly achieved. So when we talk about this, the comparator arm, there is almost a year of increment in overall survival, and that's why it becomes easier when we try to counsel our patients with this particular parameter. And this is a very important parameter for us as oncologists to, convey to our patients. Talking about this particular presentation, and this is on complement basically and Rebana study. So these two studies, and the complement is a phase 3B international study, and it's a study of ribociclib and letrozole as first line in both the sexes who have not achieved prior endocrine therapy for HR positive or HER2 negative advanced breast cancer, nearly 3,000 patients. Likewise for Rebana, this German study for real-world efficacy of ribociclib, AI or fulvestrant or endocrine monotherapy as a comparator, and chemotherapy as a first-line treatment comparator in this HR positive subset of advanced breast cancer, nearly 2,500 patients. So big numbers, both the studies. And we can see that in the complement study, the DFI of more than 12 months for the completion of neoadjuvant or adjuvant therapy was allowed if there was a hormonal exposure. Otherwise, it was primarily hormonal naive patients. There were CNS metastases which were permitted, and nearly 50 patients were there actually in this subgroup who were stable and remained stable for more than 4 weeks. And this combination was given till the disease progression. The primary endpoint of safety and tolerability, that's what the phase 3B does look at. You look at the safety and tolerability of a particular population, and secondary endpoints over there, time to progression, overall response rate, clinical benefit rate, and patient-reported outcomes. And talking about the Rebana study, it was again in the first line with a comparator. It was more of an observation study over there, with the comparator being the endocrine monotherapy, chemotherapy being there. And of course, further lines were followed and questionnaires were given, and in these particular months, almost every 3 months, as you can see, with the eligibility criteria being that they should be adult postmenopausal women, and of course, no systemic therapy. So majorly, both the trials, a lot of hormone-sensitive population, basically, as we can see, CNS metastasis allowed in the first complement one. So talking about this more, and this is actually the largest real-world study across CDK4/6 inhibitors, and that gives more confidence, that in real world, so many patients are using this particular molecule. Diverse subgroup population was there, as you can see in the various Venn diagram. This is sort of showing that all sort of patients with the visceral metastasis, CNS, prior chemotherapy, so all subset being present over there, including premenopausal ladies, diverse race. So this all was there. And when we talk about the safety profile, which was the primary endpoint, and it was predictable, manageable.
Can you please mute Vikas?
Yeah, so safety profile was predictable, manageable, and similar to phase 3 randomized controlled trials. Just a moment. So the events, as we can see the previous diagram. Yeah. So we see that neutropenia, it decreases with time, and that's what we see that in our practice as well. Neutropenia does decrease, and it's the most important thing in the first few months. Thereafter, it starts coming down, and other side effects also. Once the patient is through the first 6 months of therapy, all these side effects start coming down, and one can actually breathe easy. As we can see, the QTC is not a big issue. It's almost touching the baseline QTC prolongation events. So efficacy was prolonged, time to progression as with high event-free probability and 27.1 months, almost what we saw in treatment-naive populations. This was a median PFS of 26.7 months. And efficacy in terms of response rates, as you can see, overall response rates of the 70% and 69%, as we can see over there. Clinical benefit rate also being present. And talking about the CNS metastatic disease pattern, so we know that abemaciclib is there, and this evidence is there with abemaciclib about the CNS metastasis. But now with the complement real-world study coming up, it gives us confidence. Similar number of patients in this particular study, and these all remain majorly stable, had a stable CNS metastasis. Likewise, what we have abemaciclib data. So this was abemaciclib data is basically a phase 2 non-randomized data over there. So this gives us confidence for using this molecule in stable CNS metastasis as well. And also the PFS was not dipping. The curve was almost similar as compared to the overall population. So this is what it was with the CNS metastasis. With prior chemotherapy, as you can see, there is a slight dip in the curve, 18.4 months. Performance status, not so good. Well, there is a dip in the curve. Visceral metastasis, again, there is a dip in the curve. So these are certain factors which where we need to just monitor our patients a bit regularly and anticipate that they could be probably, failing at these particular timelines. So we have to be careful. So this is what it is. And if in case visceral metastasis and ECOG performance status 2 is there. So this is what it is. But nonetheless, this is good data in terms of efficacy for PFS. And talking about the scores of quality of life, and it was a pretty well tolerated drug as compared to the comparator. And talking about the other German study, which is ongoing prospective non-interventional observation study, basically. And you can see again, menopausal ladies, 89%, postmenopausal ladies, and premenopausal 10%. And there were visceral metastasis allowed, included rather. The brain metastasis not over here. So bone metastasis nearly 30%, and skin, unusual sort of skin and lymph nodes 24%. So again, you see that unadjusted median PFS nearly 31.7 months, quite similar again to the hormonal naive population, treatment naive population. And the safety profile was quite similar to the Mona Lisa studies. And the most frequent treatment emergent adverse effect, all grade in ribociclib AI cohort were neutropenia, nausea, fatigue, and leukopenia. So these were the adverse events, and some special interest adverse events, some transaminitis, and there was very small number of patients, some increased bilirubin level. When we talk about a comparison with the randomized control trial with this real world study, we see median PFS almost quite similar, nearly about 25 months across the board, and 31.7 months in Ravana. And when we see those reductions, they were high in the complement trial. So nearly 2/3 having got to go for those reductions. I think so. If I pose this question to my peer group, I would find answers that not many of us do need to reduce the doses. Most of us are actually finding patients coming on at 600 mg quite well. And discontinuations due to adverse event in the real world study of complement, it is nearly 12% reported, quite similar to what has been reported earlier as well. And of course, neutropenia is one of the side effects, which is more common. That's what it is. And well, we all know what are the guidelines for the recommendation of this particular molecule. It's a category 1 indication. First line therapy now in endocrine positive advanced breast cancers. And I spoke about this, that ESMO MCBS score, because of all these factors that you can see, especially the overall survival, and therefore here it lands that it's one of the preferred molecules because of the high 4 or 5 MCBS score. And when we talk about the 3 CDK4/6 inhibitors, we realize that a lot of different side effect profile, and most of the times that's the reason how we choose. Well, we can see the side effect profile is different because there is a lot of off-target activity of the other 2 molecules, as you can see. And ribociclib, it is majorly looking at CDK4 inhibition over there. Palbociclib also does the CDK6 inhibition, and therefore more of neutropenia. Abemaciclib, a lot of off-target hits, and therefore you have a lot of other side effects as well, including the GI and the lung. And you can see the CDK4 being more affected with ribociclib over there. To conclude, basically, outcomes from randomized controlled trials are being replicated in the real world experience, and guidelines recommend early usage of these inhibitors along with the hormonal therapy, and ribociclib being the only one which has the longest yet median overall survival for now, 63.9 months compared to 51.4 months in the letrozole as compared to letrozole, and there is an improvement of overall survival across lines of therapy, endocrine partner, and menopausal status with a high ESMO-MCPA score. They demonstrate similar efficacy and safety in nearly 5,800 real-world cases. It's quite effective in these subsets as well, keeping the CNS metastasis under control. Of course, there should be stable CNS metastasis, visceral metastasis under control, and chemo-treated and ECOG more than 2 also you can consider giving these inhibitors. And they are different, all the 3 molecules, in terms of off-target inhibition being there and the various side effects. And of course, efficacy would be slightly different. So, thank you.
Thank you, Dr. Piyush, for a nice presentation. I think it's been discussed time and again. I don't want to again extend the discussion further. So, Dr. AP has come back.
Yes, sir.
So I would like to invite again AP without interruption this time to finish off his talk. Dr. Dubey.
Sir, yes, sir. I'm here, sir. I'm so sorry. And sir, my Wi-Fi is of 150 Mbps. Still, sir, man, it's
Okay.
giving hookah, so I can't do anything. Sorry, I can just say sorry. So, sir, should I share, or from the technical team you'll be sharing?
I already shared, sir.
Okay. Okay. So next. This I have spoken. Can you please? Yeah. Next. 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 So BRCA mutations. Yeah, hold on. BRCA mutations have actually implicated in the treatment as well as risk stratification and family counseling, and they account for around 5 to 35% of the all breast cancer patients, more so in TNBC. Next. So the treatment of BRCA mutated cancer patients actually have lots of implication on knowing the status of germline BRCA, because these patients are the ones who have to be offered the bilateral mastectomy owing to increased incidence of second primary or the contralateral breast cancer. So this BRCA status should be known at least before the surgical procedure is being done on these patients. Next. So what are the incision criteria for BRCA testing? All the patients with the breast cancer diagnosed at the age less than 45 years, or the patient who have been diagnosed with an breast cancer at the age less than 50 years with the family history criteria, or more than 51 years with the personal history criteria, or the triple negative breast cancer or male breast cancer at any age, and also metastatic breast cancer and Ashkenazi is Jewish ethnicity patients. Next. So there is always an unmet need in patients with BRCA mutated early breast cancer, because these are the patients with young age onset of the disease, aggressive disease, recurrences, contralateral breast cancers, and quite a higher incidence of recurrence and higher incidence of CNS metastasis. And also, as I've said, that there's an increased risk of second primary or contralateral breast cancer, and also ovarian as well as other cancer subtypes. Studies have reported conflicting results about the impact of BRCA mutation and overall survival. And presently, there are no currently targeted therapy available for patients with BRCA mutated early breast cancer prior to this introduction of olaparib. Before this Olympia trial, we never had any targeted therapy for these patients with BRCA mutated early breast cancer. Next. Next. So how we actually, because Olympia trial has addressed patients who have actually higher risk of recurrence post the treatment protocol, standard treatment protocol. So how we actually stratify the patients who are having higher incidence of recurrence across the early breast cancer patient population. So the higher risk of recurrence can be actually predicted by tumor stage, the nodal status, and failure to achieve the PAT-CR. And also there's something known as CPS-EG score, which is a clinical and pathological stage post neoadjuvant therapy, and estrogen receptor status and nuclear grade score. that score also helps us in predicting the disease-free survival rate, and also as well as molecular testing, that is oncotype DX recurrence score, which we generally do in hormone receptor positive breast cancer with T2 or 1 to 3 lymph nodes. Next. So next. So now, as I have just said before, 1 or 2 slides, that the patient with early breast cancer who have germline BRCA mutation, they do not have any targeted therapy as of now, and these patients are associated with high risk of recurrence, distant metastasis, and contralateral breast cancers. So the Olympia A trial, which is a phase 3 study, which has addressed olaparib in patients with early breast cancer associated with germline BRCA mutation versus placebo as adjuvant treatment, post-protocol treatment for high-risk germline BRCA mutated HER2 negative breast cancer patients. So these patients were divided into 4 high-risk patient population, 2 in neoadjuvant group and 2 in adjuvant group. 2 in neoadjuvant group were triple negative patients who received neoadjuvant therapy but did not achieve PAT-CR, and hormone receptor positive group who received neoadjuvant therapy did not receive PAT-CR and also have EG score more than or equal to 3. Patient who did not receive neoadjuvant chemotherapy and had underwent upfront surgery, these patients had 2 risk category. One is for triple negative breast cancer patients who are having T2 or more disease, or a nodal positive disease, and in hormone receptor positive patients with more than or equal to 4 positive lymph nodes. These patients were stratified or been randomized to either olaparib 300 mg BD for 1 year vis-a-vis placebo, and the primary endpoint was invasive disease-free survival with quite many secondary endpoints. Next. So the baseline characteristics were actually well balanced between the treatment as well as the placebo arm. Next. So majority of the patient have higher grade tumor, as you can see that 78% of the patient had grade 3 tumors. Next. So this is the Kaplan-Meier survival curve, which you can see that at the end of 1 year, the olaparib actually met the primary endpoint as with the hazard ratio of 0.58 and the significant p-value 3-year invasive disease-free survival rate after 1 year of olaparib was 85.9% in olaparib arm and 77.1% in placebo arm. So there was an absolute difference of 8.8% in the favor of olaparib. Next. So this IDFS benefit associated with olaparib was maintained with 1 year additional follow-up, means that was the last slide was 3-year follow-up. This is 4-year follow-up. The olaparib arm 82.7% with the placebo 75.4% with the absolute difference of 7.3% and a hazard ratio of 0.63. Next. Olaparib also demonstrated a significant overall survival benefit that we should give it to olaparib, and with the hazard ratio of 0.68 and significant p-value, 4-year overall survival was around 90% in olaparib and 86% in placebo, a significant difference of 3.4%. Next. So around 7% or more patients treated with adjuvant olaparib were free of this distant recurrence, which was a secondary endpoint or death at 3 years versus placebo. You can see with the hazard ratio of 0.57, 3-year distant disease-free survival rate was 87.5% in olaparib versus 80.4% in placebo. Again, an absolute difference of 7.1%. Next. So longer follow-up confirms that distant disease-free survival of adjuvant olaparib versus placebo was maintained. Even at 4 years, you can see that with olaparib it was 86.5% and only 79.1% with the placebo arm, with the absolute difference of 7.4% and the hazard ratio of 0.61. Next. So one important thing, because the germline BRCA mutated breast cancer patients are associated with higher incidence of contralateral breast cancer or the second primary. Here you can see that the second primaries were reduced to 50% in the olaparib arm versus placebo arm, and also the regional as well as local recurrence were also significantly decreased. Next. There was a consistent benefit was seen across all the subgroups in the terms of invasive disease-free survival. You can see in this forest plot, which was irrespective of prior chemo protocols, whether or not patient received platinum and hormone receptor status, and whatever which subtype of BRCA or which BRCA gene patient is mutated of. Next. The similar distant disease-free survival was also all the subgroups were benefited with this adjuvant olaparib for 1 year. Next. OS benefit was also seen to be derived in all the subgroup patients, which were irrespective of the chemo, platinum drug received or not, hormone receptor status, and the BRCA gene mutation subtype. Next. So what about the number of patients and what about the adverse events? So more than 70% of the patient actually completed the treatment. And you can see that it was 71.2%. And around 75% of those patients did not require any dose reduction. Yes, 25% required dose reduction. And most of those patients were because of certain or the other adverse event. Next. So 10% of the patient discontinued treatment due to adverse event. Next. And the adverse events next. So adverse events were actually observed, which were consistent with all the other trials of olaparib. They were more of gastrointestinal and hematological events, which could have been very well controlled with the dose modification. Next. Blood transfusion, though, because hematological adverse events were one of the most common adverse events of olaparib, but blood transfusion was being done only in around 6% of the patient. Next. So also there was no clinically meaningful change in fatigue severity across the duration of the study, because fatigue is also one of the common adverse events of the targeted therapy, all the targeted therapies, and so on for olaparib 2. Next. And also the clinically meaningful difference in the nausea and vomiting, because gastrointestinal events are one of the most common adverse events with the olaparib. So these were also small and resolved after the treatment cessation. Next. So these are the guidelines which actually recommend patient with HER2 negative, high risk germline BRCA1, BRCA2 mutated patient to be offered 1 year of adjuvant olaparib, and irrespective of what patient has received neoadjuvant or adjuvant and whatever chemotherapy protocol patient has received, based on this Olympia A study, which have shown improved outcomes in these subgroup of patients. Next. So similar guidelines from ASCO. ASCO has shown that the patient with germline BRCA mutated breast cancer, if they have received adjuvant therapy, then the hormone receptor patients who are having more than 4 axial lymph node positive, or in patients with more than T2 disease or node positive in triple negative subgroup, or patient who have received neoadjuvant chemotherapy, have not achieved PAT-CR in triple negative breast cancer patient, or in hormone receptor positive patient, where either the patient has not achieved PAT-CR, and also plus CPS-EG score is more than or equal to 3. Next. The same goes for St. Gallen's consensus guidelines. The patient with stage 2 or 3 HER2 negative breast cancer should be offered adjuvant olaparib. Next. So other drugs which are being already recommended in patients with early breast cancer, one is capecitabine, based on CREATE-X study, which have shown that patients who have treated with upfront neoadjuvant chemotherapy followed by surgery, and these patients who have not achieved PAT-CR were being offered either capecitabine versus placebo, or versus wait and watch. These patients have shown that the patients who have not achieved PAT-CR and receives capecitabine have actually improved outcomes, significantly improved outcomes with capecitabine. Next. This is an intent to treat population. Disease-free survival was seen. The benefit was seen in the whole group of population as well as the overall survival. Next. But this disease-free survival was much more prominent in patients with triple negative breast cancer patient, and same goes for the overall survival too. Next. So the adverse events of capecitabine, we all are aware that either it is hematological or it is gastrointestinal, but the grade 3 or more adverse events were around less than or around 5% of the patients only. Next. So NCCN and ESMO guidelines both recommend capecitabine as adjuvant treatment in patients for triple negative breast cancer who have received neoadjuvant chemotherapy and have not achieved PAT-CR post-surgery. Next. So the last few slides about the immunotherapy in triple negative breast cancer patients. This is Keynote 522 trial, which is a phase 3 trial of pembrolizumab plus chemotherapy as neoadjuvant therapy and pembrolizumab monotherapy as adjuvant therapy post-surgery in early stage triple negative breast cancer, where patients were randomized to pembrolizumab plus chemotherapy vis-a-vis only chemotherapy plus placebo, and followed by surgery and adjuvant pembrolizumab as adjuvant 9 cycle in patient who have received new adjuvant pembrolizumab vis-a-vis placebo, whether the primary endpoint was PATH-CR and investigator assessed event-free survival. Next. So the baseline characteristics were coupled between the placebo arm. Next. So it was being seen that the PATH-CR was significantly increased with the addition of pembrolizumab to chemotherapy in patients with triple negative breast cancer. And also the first event-free survival analysis has also shown that the patients, the number of events were significantly lower in patients who received pembro plus chemo followed by surgery, followed by pembro as adjuvant or as maintenance therapy for 9 adjuvant cycles. Next. Next. So event-free survival was strongly associated with PATH-CR, and PATH-CR there was around 14% increase in PATH-CR with the addition of pembrolizumab. Next. And among the patients with residual disease at surgery, there was a lower percentage of patients in each residual cancer burden category in pembrolizumab arm. So pembrolizumab arm increased the PATH-CR rate, and also the patient who have not achieved PATH-CR, it has shifted the residual cancer burden to lower category across the entire spectrum of residual disease. Next. So next. So we know that there are certain immune-mediated adverse events which can be very well managed with supportive and symptomatic care. Only with grade 3 or grade 4 adverse event, we have to stop the therapy till the patient revert back to grade 1 or grade 2 adverse event. Next. 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 So the last is CDK4/6 inhibitor in early breast cancer, that is abemaciclib. Next. So Monarch E investigates the adjuvant endocrine therapy plus minus abemaciclib in patients with high risk node positive hormone receptor positive breast cancer patients. Here, hormone receptor positive breast cancer, HER2 negative breast cancer, who have received the protocol treatment, and they were certain high risk of recurrence. Those high risks were either more than or equal to 4 lymph node positive, or 1 to 3 axillary lymph node positive, plus at least one of the following, that either T2 or more disease, histological grade 3, or Chi67 index more than 20%. So these patients were randomized to abemaciclib 150 milligram BD up to 2 years, plus standard of care endocrine therapy or standard of care endocrine therapy alone. And the primary endpoint was invasive disease-free survival. Next. So it has shown that abemaciclib has actually improved the disease-free survival in patient, distant relapse-free survival in the patients who have actually received abemaciclib along with hormonal therapy as compared to hormonal therapy alone. Next. So this was both premenopausal as well as postmenopausal. I mean, irrespective of the menstrual status, the patient have actually achieved the benefit of invasive disease-free survival. Next. So the safety profile of abemaciclib plus endocrine therapy in Monarch E was consistent with previous studies. We all are aware that adverse event, the most common adverse event with abemaciclib is gastrointestinal, that is diarrhea. But grade 3 or 4 adverse event, which that is diarrhea, was in only less than 10% of the patient. Next. Though abemaciclib has shown improved outcome in the terms of distance recurrence-free survival or invasive disease-free survival, but palbociclib has actually failed to show the similar benefit in patients with breast cancer, early breast cancer with high relapse risk after neoadjuvant chemotherapy and the protocol treatment. Next. 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 So I conclude my talk that all the patients who actually fulfill the criteria of BRCA testing should be tested. That is, all the patients who are less than 45 years of age, diagnosed as breast cancer, or less than 50 years of age with family history, or more than 50 years of the age with personal history, or any age with triple negative breast cancer should be actually offered testing for germline BRCA mutated testing. And the value of identifying this high penetrance mutation in breast cancer is very well established, as because it impacts treatment, it impacts surgery, it impacts adjuvant targeted therapy, it impacts the risk stratification and family counseling. The Olympia trial is the first trial which has shown the clinical benefit in the terms of invasive disease-free survival and overall survival of the first targeted therapy in this subgroup of the patient with PARP inhibitor as an adjuvant treatment in patient with germline BRCA mutated HER2 negative early breast cancer at high risk of recurrence. And also, apart from this olaparib, we have certain other drugs like immune checkpoint inhibitors, pembrolizumab, where the neoadjuvant therapy, that is chemotherapy plus pembrolizumab, followed by surgery, followed by pembrolizumab maintenance for 9 cycles, have improved outcome in the term of improving the PAT-CR and also improving the outcomes. And also, we have abemaciclib in patient with hormone receptor positive breast cancer patient with high risk of recurrence with more than 4 axial lymph node positive, or patient with less than 4 axial lymph node positive who are having a high grade or T2 or more tumor. These patients should be offered abemaciclib along with hormonal therapy. And also in patients with early breast cancer, triple negative breast cancer who have residual disease post neoadjuvant chemotherapy should be offered capecitabine because it has also improved outcomes. Understanding the role of these agents in the light of existing therapies allow us to optimize the treatment strategies. Still, there is unmet need in early breast cancer remains to be challenges in early detection due to lack of proper screening, because in our country, only 30% of the patients have early breast cancer at the diagnosis, and around 70% of the patients have either locally advanced or the advanced disease. So the screening and has to be actually done very intensively in all the females who are more than 40 years of the age, or the patients who are having a family history should be screened at least less than 40 years of age, depending upon the first onset of the breast cancer in the family. Thank you. Thanks a lot.
Thank you, Dr. Dubey, for a nice presentation. A lot of questions to be asked that because of the constraint of timing, so we'll probably discuss when we'll have a physical meeting. A lot needs to be discussed in this particular segment. Next speaker doesn't need any introduction, Dr. Manish Shingal. So he'll be speaking on Pivecto. So that is PIking the right strategy for patients with hormone positive HER2 negative PI3K mutant MBC. Over to you, Dr. Manish.
Hi, thank you very much. Can I request the slide set to be shared? And of course, this is one slide set that you must have seen, or all of us would have seen many times.
Yes.
But it's always good to have a revision, just to help us reconcile with everything else. So, this is about Pivecto, and we can go to the next slide. So this is piking the right strategy for the HR positive, HER2 negative, PIK3CA mutation positive patients. Next slide. We know that, next slide. So we know that the PIK3CA positive or mutation positive breast cancer accounts for about 40%. Next slide. And this accounts for worse prognosis, and this has been studied in various patients' data set, which says that the presence of PIK3CA mutation has a negative prognostic factor and is associated with worst outcome and poor response to chemotherapy or for that matter hormone therapy. And this can be a biomarker of response, and therefore there has been ardent interest in having a PIK3CA inhibitor. And before the Pivecto came into being, there had been a lot of PIK3CA inhibitors which came into being but then vanished away from the market because of toxicity. Alpelisib is a specific PIK3CA inhibitor, and this has passed through the randomized controlled trial, which is the SOLAR-1 study. Next slide. So PIK3CA mutation is, as already said, that it is responsible for poor prognosis, endocrine therapy resistance, tumorigenesis, and cell proliferation, and therefore it is important to know the PIK3CA mutation status. From the very fact that now we can target it. And next slide. This is usually given in combination with fulvestrant, and targeting the PIK3CA mutation overcomes the resistance to endocrine-based therapies. And the Pluvicto inhibits the alpha isoform of the PIK3CA 50 times more potently than other PIK3CA isoforms. Next slide. So this passed through the randomized control trial, which is called as the SOLAR-1 trial, where 1:1 randomization was done in patients who had progressed after their hormone therapy in a metastatic breast cancer setting and harbors a ECOG performance status of 0 to 1. 1:1 randomization to Pluvicto 300 milligram OD plus fulvestrant versus placebo and fulvestrant. Median progression-free survival was the primary endpoint. There was key secondary endpoints were overall survival, overall response rate, clinical benefit rate, safety, and quality of life. Next slide. So trial met its primary endpoint. There was doubling of the progression-free survival from 5.7 months to 11 months with Pluvicto, and there was a rapid separation of the PFS curves with a hazard ratio of 0.65 with a p-value of 0.00065. So this fetched Pluvicto a category 1 indication in the NCCN guidelines for treatment of metastatic breast cancer, which are HR positive and HER2 negative. Next slide. Consistent results across various subtypes and subgroups, and prior chemotherapy, CDK4/6 inhibitor, although CDK4/6 inhibitor was used in a minority of patients, but now we have another BILEAV data set which shows that it works even after CDK4/6 inhibitors, although the PFS falls down to around 7 months in that case. So all subgroups were benefiting. Next slide. Response rates were again doubled up, almost from 16% to more than doubled to 35%. And also the overall response rate with those patients who had measurable disease also almost doubled up. So there's definite improvement in the response rates. Next slide. So the recommended dose is 300 milligram OD, but seldom patients are able to tolerate this, and fulvestrant is in the standard dosing of 500 milligram day 1, day 15, day 29, and then once monthly. Next slide. Various other dose levels are 250 milligram and 200 milligram. As far as adverse effects, if you look at grade 3-4 adverse effects, stomatitis, vomiting, diarrhea, relatively less than 10%. Fatigue is again less than 10%. Rash is common in case if you don't use antihistaminic drugs. Hyperglycemia perhaps is the most common metabolic or nutritional disorder which happens with Pluvicto, and there's tough time controlling the hyperglycemia. Next slide. Hyperglycemia is a on-target effect because PIK3CA is responsible for driving the insulin inside the cells, and which is inhibited. Therefore, there is hyperinsulinemic state and hyperglycemic state. So giving more insulin doesn't really help in this situation. You have to actually withdraw the drug, then only the insulin can work in case you are encountered with a very high glucose levels. So usually the drugs which increase insulin sensitivity is something that works. So metformin remains a drug of choice. Next slide. So these are the guidelines for dose modification. The fasting plasma glucose, if it is within 160 of the 160 to upper limit of normal, you need not do any dose reduction, but you can definitely start some anti-diabetic measures. Whereas if it is 160 to 250, then you got to you may have to reduce the dose, but you can continue the dose and start anti-diabetic measures. But if it is 250 and 500 or more than 500, you got to stop alpelisib for some time, decrease it to grade 1 or lesser, and then you can restart at lesser dose levels or may have to omit alpelisib altogether. Next slide. Of course, it requires a basic understanding of how to treat the hyperglycemia induced by alpelisib. Most of the patients will be able to tolerate around 200 to 250 milligram. I've never been able to reach 300 milligram in any patient. It's very difficult because hyperglycemia actually is something which really encumbers correct dose delivery. Proper exercising, limiting the trans fats, limiting carbs intake, increasing protein intake, having a exercise schedule can definitely help patients fight this hyperglycemia, and so as they can benefit from alpelisib and continue taking alpelisib unencumbered. Next slide. So this is a monitoring schedule, and we got to check plasma glucose quite frequently. Although it says HbA1c every 3 months, but I think we've got to do it more frequently, and even the fasting plasma glucose and glucose levels have to be done more frequently in most patients. Not really as per the guidelines, but more frequently, because we have had patients where the sugar levels have reached almost 300, 400 plus, and it becomes really very difficult to manage it otherwise. Next slide. So for rash, it's better to start patients on antihistaminic drugs right from the very beginning so that you don't encounter rash. The incidence of rash decreases drastically if you prophylactically use antihistaminic drugs even before starting Pluvicto. Next slide. So where to test, when to test, of course it is important because it carries a worse prognosis, and then now there's a biomarker driven therapy which can be given, which is Pluvicto. Earlier you test, the better it is, because sometimes there can be DNA degeneration in the archival tissues, and sometimes it is not easy to take biopsy in a recurrent setting when you have bone only metastasis. So it's better to test as soon as possible. The exons which are studied is 7, 9, and 20, and the tissues, any tissue can be tested, either the metastatic tissue or the primary tissue, and there are approved TheraScreen PIK3CA kits which are available, and now the test can actually be carried out free of cost as well. Next slide. In case there is no way the tissue is available, even a liquid biopsy using ctDNA can be done in a good lab, and if tested positive, one can offer Pluvicto plus fulvestrant to these patients. Next slide. So to quickly summarize, PIK3CA mutation are present in about 40% HR positive HER2 negative advanced breast cancers and indicate a poor prognosis. It's a mutation which is targetable, and the drug in question is alpelisib. Doubles up your median progression-free survival, so is the response rates. Safety concerns are well listed, and they are manageable if one strives hard to manage these side effects and educate patients to have a particular lifestyle and diet to help them tolerate the side effects of Pluvicto. And the evidence is in favor of using this combination with fulvestrant. With that, thank you very much, and over to the organizers.
Thank you, Dr. Manish. Again, the crisp, nice, very good presentation with covering all the points as always. Thank you very much.
My pleasure.
So next, I'll invite the next session that's sponsored by Roche. So role of atezolizumab in metastatic TNBC. May I invite Dr. Pooja Babbar, who is a medical oncologist at CK Birla Hospital, Gurugram. Over to you, Dr. Pooja.
Thank you, everyone. Thank you, sir, for giving me this opportunity, and also thanks to Roche. Can someone share the slide?
Yes, ma'am, on it.
Is it visible?
Yes, ma'am, it is visible. Can you make it full screen?
Slides are visible?
Yes, ma'am.
Right, ma'am.
Yeah. So I'll be speaking on role of immunotherapy in triple negative breast cancer. As we all know, breast cancer is the most frequently diagnosed cancer in the woman, and it is second among the cause for cancer-related death. There has been enormous literature, which we have seen in the last talk, which has shown that there's a continuous research going on, which has an implication in improving the clinical outcome in breast cancer. So as we all know, it's a heterogeneous disease. Peru et al. Has classified breast cancer into 5 to 6 subtypes based on gene expression profiling by complementary DNA assay, and has classified breast cancer into luminal A, B, normal-like, HER2-enriched, and basal-like breast cancer. So the classification is also based on histology. As we all know, the histology is broadly classified as invasive carcinoma and in situ carcinoma. In invasive, we have different varieties like tubular, lobular, mucinous, medullary, papillary. And in terms of molecular classification, as I have already discussed, it is luminal A, B, HER2-enriched, basal-like, and normal-like breast cancer. So as we move on to the characteristics of these breast cancers, so as we know, the basal-like breast cancer usually have the basal markers, which are cytokeratin 5, 6, and EGFR positive. Now, in triple negative breast cancer, there are two types. One is the So in triple negative breast cancer, there are two types of breast cancer. 70% of them are basal-like, which has these basal markers, and 30% is the normal breast-like. So moving on to triple negative breast cancer, as we all know, it accounts to 10 to 20% of breast cancer cases worldwide. It is highly prevalent, and especially among Indian population, the incidence is more, probably 30%. Majority of these cancer usually present in advanced stage or as a metastatic stage. The median age of presentation is also a younger age group, which is 49 years. Now, as we all know, triple negative breast cancer doesn't have any target. It lacks the expression of ER, PR, and HER2. That's why it is more difficult to treat. And chemotherapy has been the mainstay of treating these cancers since past 20 years. The second graph is showing the 6 unique subtypes, which is given by Lehman et al. And again, which has classified TNBC into basal-like 1, 2. Basal-like type is actually enriched in cell cycle repair and DNA repair genes. These are mesenchymal stem cells, and mesenchymal, which works on EMT, PI3, AKT, mTOR pathways. Then we have luminal androgen receptor type, which are very which has a very good, which are like adenoid cystic histology, and they express luminal androgen receptor. And immunomodulatory, as we all know, they have immune signals. They are rich in immune signals. They are rich in interleukins, T cell infiltrates, TILs, and JAK-STAT pathways. So coming to the characteristics of TNBC, they are aggressive. They are usually presenting at advanced and metastatic stage. They are grade 3. The tumors are larger at presentation. Mortality rate is high. They are quite aggressive tumor with high rate of distant recurrences. And the rate of distant recurrences or the local recurrences is usually seen more common in first three years as compared to other cancer. So as I discussed earlier, the mean time of distant recurrence is lower for TNBC. It is usually in first 2 to 3 years. And however, we say the survival has not gone beyond 15 to 18 months with the chemotherapy being used in first line setting. And now in this slide, as it is depicted, the survival rate, TNBC survival is quite poor as compared to other breast cancer subtype. So that defines that there's a high unmet clinical needs because the recurrence rate are high, overall survival is poor, we do not have any target, and we cannot achieve the survival beyond 15 to 18 months with the chemotherapy. So coming to the role of immunotherapy in triple negative breast cancer, it is a subtype in breast cancer which shows high T cell infiltration. The T cell infiltration rate is probably the highest, which is 30%. And there are 3 factors which contribute to high response rates to immunotherapy. First, the tumor infiltrating lymphocytes are more. Second, there are high rates of mutation, almost 13.3 more as compared to normal cells. The more the mutation rate, the more is the generation of new antigens, which can induce immune responses. And third is more presentation of PD-L1 and PD-1 on immune infiltrating cells and tumor cells. So as I earlier discussed, these are the reason. And with each 10% increase in the level of tumor infiltrating lymphocytes, there's a reduction in the risk of death and distant recurrences. So the PD-L1 expression, which is observed in advanced triple negative breast cancer, is usually more than 50%. And that's why targeting this agent can actually enhance the immune response. Again, this slide is showing the same thing. So again, this is showing the PD-L1 pathway. It downregulates the anti-cancer immune responses at 2 levels. Actually, PD-L1 expression binds to PD-1 and B7 receptor, and it actually prevents the anti-cancer T cell immune responses. So however we treat, whether in the first line, second line, the prognosis is poor, the maximum survival is 15 to 18 months. And whatever options we have are the options in chemotherapy. In first line being the taxanes and platinum combination. In second line ranging from anti-metabolites like capecitabine, gemcitabine, and antimicrotubules like eribulin. So now coming to the IM Passion 130 design and result. So IM Passion 130 is a phase 3. It's a big randomized phase 3 multi-center trial. The eligibility criteria was metastatic or inoperable locally advanced triple negative breast cancer. In the metastatic setting, there were 40% of the patients who were upfront de novo metastatic, and 60% of the patients were triple negative breast cancer in curative settings, which has received a prior chemotherapy, and also they were allowed if the treatment-free interval was more than 1 year. And any PD-L1 status, they were stratified based on prior taxane use, liver mets, and PD-L1 status. So they were randomized 1:1 fashion to 2 arm. One is Tecentriq plus nab-paclitaxel with the schedule of day 1, day 8, day 15, 100 milligram per meter square of nab-paclitaxel, and Tecentriq 840 mg IV day 1 and day 15. The second arm was placebo plus nab-paclitaxel. So here the primary endpoint was PFS. It was a hierarchical design statistical analysis. First, the PFS was analyzed in intent to treat population and then in PD-L1 positive population. Thereafter, moving to overall survival in ITT and then PD-L1 positive population. Secondary endpoints were overall response rate, duration of response, and safety. So the choice of nab-paclitaxel, as we all know, nab-paclitaxel doesn't require steroid-free medication. And that's why, as we know that steroid impact immunotherapy activity, so this drug was chosen. And the results were quite consistent and interchangeable with paclitaxel. And the dosing of 100 milligram per meter square was used. The efficacy was same, only the safety profile was better as compared to 150 milligram per meter square. So as I earlier explained the hierarchical design, the analysis was primary PFS in ITT and then in PD-L1 positive population. If it was positive, the further testing interim analysis was for overall survival, first in ITT and then in PD-L1 positive population. So the randomization of 902 patients equally divided into both experimental arm and the placebo arm. And the baseline characteristics were matched in between both the arms. The only thing is the PD-L1 positivity was 40% in Tecentriq arm, and the exposure to prior taxanes were 50%. Almost half of the patients were pre-treated with taxanes or anthracyclines. So coming to the analysis, in primary PFS analysis, when we see intent to treat population, so here there was an improvement in progression-free survival from 5.5 months to 7.2 months. And after that, the PFS analysis was done by PD-L1 status. The benefit was from 5 months to 7.5 months, which was quite significant and pronounced in patient with PD-L1 positive. So then there was an interim overall survival analysis after a follow-up of 13 months. In ITT, though there was a numerical increment in survival from 18 months to 21 months, but it was not significant. It did not cross the boundary of statistical significance. And an informal statistical analysis was done on overall survival analysis by PD-L1 status. And though the survival is clinically meaningful, we have crossed beyond 2 years. The survival is almost 25 months in Tecentriq plus nab-paclitaxel arm as compared to placebo plus nab-paclitaxel arm, which is 18.4 months. But it was an informal statistical analysis because of the hierarchical design. And when we go to subgroup analysis, then all the patient who were PD-L1 positive derived the maximum benefit. And the secondary endpoint, the response rates were more in PD-L1 positive population, around 60%, and 10% were complete responders in Tecentriq plus nab-paclitaxel arm as compared to the placebo plus nab-paclitaxel arm, which was 1%. Now coming to the safety analysis, the adverse event of special interest. So actually there was no much increment in adverse event by giving Tecentriq with nab-paclitaxel. Whatever events were there were due to nab-paclitaxel. Though the adverse events were slightly more to the tune of 5 to 6% in Tecentriq plus nab-paclitaxel arm, but the fatal events were hardly 1.3%. The more common events were peripheral neuropathy, neutropenia, fatigue, and anemia. So the adverse events were more or less similar between two arms. It did not require additional safety monitoring or any supplementary monitoring when we are giving Tecentriq. It is quite tolerable drug with major side effects, though the side effect being hypothyroidism. Hypothyroidism was more 2%, but it did not resulting in the withdrawal of the Tecentriq arm. So updated efficacy and safety results from second interim analysis. So again, in the second interim analysis also, when we compared in the PD-L1 positive population, there was an improvement in overall survival. So when we talk about the safety analysis, more or less both the arms were equal. Only 1% fatal events were there in atezolizumab plus nab-paclitaxel arm. Along with that, 6% grade 3, grade 4 adverse events were more common in Tecentriq arm. Treatment interruptions were there in 31% of the patients who were in Tecentriq arm. So it is the first phase 3 study to demonstrate a benefit with cancer immunotherapy in metastatic triple negative breast cancer. Definitely it is a practice changing study, because here we are able to achieve the survival which is beyond 2 years. And secondly, we do not have any other targeted therapy presently available for these patients, considering the aggressive nature of the disease and chemotherapy being the only option. Third, safety-wise also, there are no additional concern. Fourth, the baseline characteristics were quite comparable in both the arms. So definitely this could be a practice changing in the first line treatment of metastatic triple negative breast cancer. And as we all know, the survival in PD-L1 positive population was 25 months. And the biomarker testing which was used in this particular study was SP142. And the IC was more than 1%. IC is the percentage of immune cells, the area which is occupied, the tumor area which is occupied by immune cells were more than 1%. And the patient in which the PD-L1 was more than 1% were deemed positive by SP142. And these are the patients who have shown the maximum survival benefit going up to 25 months. So to summarize, as we know, the incidence of TNBC is high, almost reaching up to 30 to 40% in India. It is quite an aggressive disease, high relapse rate, and that's why a poor prognosis. Treatment options are very limited. We only have chemotherapy. So in this particular study, especially in PD-L1 positive, we could actually reach to a clinically meaningful 25 months median overall survival benefit. So definitely it's a first phase 3 study to demonstrate a benefit of immunotherapy in triple negative breast cancer. And the biomarker which is used is SP142, which require IC to be more than 1% to be eligible for this drug. And the benefit risk profile also supports a change in the practice in the first line treatment of metastatic triple negative breast cancer. So definitely first it was approved by US FDA in 2019. And then it was also withdrawn considering the negative results of IM Passion 131 study, which showed a negative result with paclitaxel. But considering the limiting options which we have currently for triple negative breast cancer, we can actually consider this study and continue to use this drug in clinical practice. Thank you so much.
Thank you, Dr. Pooja, for a nice and lucid presentation. And I'll invite next speaker. Thank you very much. So I'll invite next speaker, who is my colleague at BLK Max, Dr. Vidushi. Sorry to disturb your vacations. Thanks for making it even during your vacations. So she'll be speaking on a flexible future, transforming the paradigm HER2 positive breast cancer treatment. Over to you, Dr. Vidushi. Dr. Vidushi is there?
Yes, sir, she is here.
Okay.
Vidushi ma'am, your voice is not there.
Is she muted?
No, sir, उनका mute भी नहीं है.
Hello. Good evening, everyone.
It's audible.
Am I audible?
Yes. Yes, Dr. Vidushi, it's audible.
Good evening, sir. Thanks for giving me the opportunity. I'm having some small hiccups with the connectivity.
Okay.
Am I visible and audible?
Yeah, you are.
I'll be just sharing my screen. Is my screen visible?
Yes,
Yes,
ma'am.
it is.
Perfect.
Yes.
Perfect.
All right. So good evening, everyone. Today I'll be talking about the flexible future we have with transforming the paradigm of the HER2-positive breast cancer patients. We know that a lot of research is going on in this area, and we have a lot of new molecules. We have a new preparation of the older existing molecules. So, pertuzumab, trastuzumab, we already know this has transformed the treatment landscape and is the standard of care for patients with HER2-positive breast cancer, be it in neoadjuvant setting, the adjuvant setting, or the metastatic setting. So, coming to the neoadjuvant setting, we use it for the locally advanced breast cancer patients who are at the high risk of recurrence. The pivotal study in this arena is NeoSphere study, and we have seen that addition of pertuzumab to trastuzumab in addition with chemo has significantly improved the pathological CR rates from 31% to 49% compared to trastuzumab and chemotherapy alone. The additional supporting studies in this area are Trifina, Burmese, and Peony. Coming to the adjuvant setting, I feel that the data here is little deeper. The FFP study, here the addition of pertuzumab and trastuzumab in combination with chemotherapy reduced the recurrence by 23%, and in patients with positive breast cancer, it reduced it by 28%. And the additional supporting studies here are Burmese. The strongest evidence, in my opinion, is metastatic setting, where Cleopatra data is there, and the addition of pertuzumab to trastuzumab in combination with chemotherapy has increased the median PFS from 12 months to 18.5 months, and the median OS has also significantly improved from 56% from 40 months to 56.5 months. The additional studies here are for use. So we already know that pertuzumab trastuzumab combination in chemotherapy is approved and recognized by national guidelines, and is the standard of care for patients with HER2-positive breast cancer. So HER2-positive breast cancer, this is the early as well as locally advanced breast cancer patients. This is the treatment algorithm we follow. So coming to the right arm of these algorithms, T1 negative patients, they undergo surgery upfront, and out of these negative patients can take only trastuzumab paclitaxel 18 cycles. The node-positive patients, based on the FT data, here there is some evidence for improvement with addition of pertuzumab, and this also goes on for 18 cycles. Coming to the left arm of the algorithm, any patient who has a tumor size more than 6 centimeters or is positive, we initially give therapy in the neoadjuvant setting in combination with pertuzumab, trastuzumab, followed by surgery, and if there is complete response, then we continue the same regime for 8 cycles. If there is, however, residual invasive disease, the indication is for switching over to TTM1 for 3 cycles. Now, the data is there for the population of trastuzumab, but the IV, it can present challenges to patients and to the healthcare systems. So the challenge is number one is the long infusion and the observation time, which leads to congestion at the clinics and the hospitals. Pertuzumab, the loading dose is 60 minutes infusion time followed by 60 minutes observation, and for maintenance this time is 30 minutes infusion followed by 30 minutes observation. For trastuzumab, again, it's a 90 minutes infusion time in the first dose and subsequent 50 minutes, and observation for 2 to 6 hours. The other problem is the challenge of improving the resource utilization. So the IV preparation takes longer time rather than those subcutaneous and requires associated resources. IV access, as we all know, in the breast cancer patients, there are challenges in accessing the venous system, the placement and maintenance in fixed access. It's a challenge. So it can repeated usage of keyboard or pick line, it can cause infections, and it is discomfort causing. And some patients can have particularly bad issues with poor venous access and it is particularly burdensome. So, keeping this in mind, PESCO is the first formulation in oncology which combines two monoclonal antibodies. So, we have had molecules like rituximab, subcutaneous, or trastuzumab alone subcutaneous, but this is the first formulation. We have the combination of monoclonal antibodies, pertuzumab and trastuzumab in one vial for subcutaneous injection. It contains the same antibodies as our IV therapy, but the administration it has in combination. Apart from these two molecules, it is combined human hyaluronidase, which allows for subcutaneous administration of high drug. So the volume that we need subcutaneous usage in this is 15 ml for loading dose and 10 ml the maintenance dose, which is quite a high volume. And the recombinant hyaluronidase helps the easy dispersion and absorption of this drug. It is available as a ready-to-use fixed dose formulation, and it requires subcutaneous injection in the thigh of approximately 5 to 8 minutes. The mechanism of action essentially is the same as we all know. Pertuzumab and trastuzumab. Pertuzumab works on the HER2 molecule as a proven HER2 blockade agent, and pertuzumab targets subdomain on the HER2 receptor rather than trastuzumab block dimerization of HER1 and HER3 receptors, and it provides a dual blockade of the HER2 signaling pathway. The molecule hyaluronidase allows subcutaneous delivery of larger molecules. How it does it? It increases the permeability of the subcutaneous tissue by depolymerizing hyaluronan, and the effects are versatile, and it increases permeability of subcutaneous tissue for 24 to 48 hours, and after that it's restored. So this is how it works. This layer contains a matrix of hyaluronan fibers and collagen fibers, which otherwise limit the administration of polyps up to 1 ml only. When we add the recombinant days temporarily and degrades the of hyaluron at the injection site, and there is no change in the structure of other macromolecules like collagen or elastin, and the degradation of hyaluron that results in temporary increase in substitution area, enabling large volumes of fluids to be administered. And after administration, the architecture of the skin is reformed within 1 to 2 days due to rapid clearance of this molecule, and there is a fast hyaluron turnover as well. So, a picture says 1,000 words. So, without a recombinant hyaluronidase, include this drug, there will be large volume collections at the same site. But when we give this hyaluronidase, it gets absorbed easily and quickly. So, the test for any subcutaneous molecule is that whether it has the same pharmacokinetics, efficacy, and safety as the IV molecule. So, let's explore that. So, when PESCO, the clinical developmental design, first they conducted a study, the B30185 study, the phase 1B study, which was completed in 2018. This was for finding and confirming the dose for pertuzumab within the PESCO molecule. Trastuzumab, we already know there is a subcutaneous formulation available. This was particularly targeted at finding the subcutaneous dose of pertuzumab. So, the results of this study, they found PESCO loading dose to be 1200 in combination with 600 trastuzumab, whereas the maintenance dose is 600 pertuzumab in combination with 600 trastuzumab. The further studies in this area have been finding the pharmacokinetics, safety, and preference. The Federica study, which is a phase 3 early cancer study, is ongoing. Anti-analysis was presented in breast cancer conference in 2019, and the Francesca study, which is a phase 2 study in early breast cancer, is ongoing, and the anti-analysis has been presented at ESMO in 2020. This is the dose finding study, the B30185. There, the part 1, they had healthy late volunteers. There were around 8 cohorts, all of 6 numbers, and they found which is best combination for treating and for maintenance dose of pertuzumab. And later they had 3 cohorts. This is part 2 of the study. They had early breast cancer patients, and the 3 cohorts were of each of 20 in number. This study selected a dose of 1200 milligrams as subcutaneous and so 600 to be used in TESCO. And these doses will be equivalent to that of the IV Perjeta, 40 mg followed by 420 mg. The dose finding processes used to find doses of pertuzumab were very similar to those used in the development of Septane and there were no new safety signals observed for pertuzumab alone or that co-mix of formulated with substitutes, and the comparative safety results supported further development of this. Now, coming to the next study, where this is a phase that we come to the phase 3 non-periodic study assessing the pharmacokinetics, efficacy, and safety. So, here they had patients specific confirmed operable or locally advanced HER2 positive breast cancer, more than 2 centimeters of patients. The number was 500. It is not okay. Arm A had chemotherapy, started chemotherapy in combination with IV preparation of pertuzumab and trastuzumab. The arm B was the same kind of chemotherapy in combination with subcutaneous preparation of these drugs. The patients, after the neoadjuvant therapy, they were allowed to undergo surgery and then subsequent IV preparation or subcutaneous preparation followed for 40 weeks. So here we have stratified the patients of what is the hormone status, clinical stage presentation, and type of chemotherapy. The primary endpoint was in therapy of the cycle 7 dose. So they were 3 doses at cycle 8 of the serum of concentration. The other secondary endpoints that were included for the non-inferiority of the septal trastuzumab concentration, the pathological CR rate, safety, disease survival, event-free survival, and broad survival. So, pharmacokinetic support for pharmacokinetic parameters. So, the most useful is the drop concentration of the molecule of interest related to the mode fraction as well as in the clinical outcomes. The other parameters that capture the area of the plasma concentration, time curve. This may also correlate with the drop concentration, and it provides information over the course of the treatment cycle. This Emax is the maximum concentration that is there, but it does not correlate with the clinical outcomes. It does not show in studies. But Rika here, they found that the drop concentration on the cycle 7 dose, 3 dose, cycle 8, they found that the concentration is non-inferior. It is 88%, 88% for the arm versus 7.6 the IV arm. And that of the trastuzumab drop concentration was also better in the substance 7.5 versus 3.2 for the IV. The other secondary endpoint that we had in this was pathological response rates. This is identical to the IVD population. In the group, it is close to 59.5 for both the arms. When they had stratified it by the body mass index, most of the groups equivalent, but the underweight patients, the number is 10 only, in the IV arm and secondly sub-arm. We can see there is considerable difference. It was percent response to the IV arm and 50% to the arm. So I feel this speaks more whether underweight patients can be formulation. So coming to the safety profile, comparable within the substance as well as the IV arm. Anyway, it was practically present in all the patients. Grade 4, but in around 60 patients. Serious adverse events from 16% was observed in both the groups comparable. Only one death in the groups, and the discontinuation rate. So the discontinuation rate in a substance arm is 6.9% versus 10% of IV arm. However, statistically, this is completely similar. The most common adverse effects, but also the other side effects balance between the arms, anesthesia, nausea, diarrhea, and comparable. Then the other adverse effects of interest is very cardiac dysfunction. Cardiac dysfunction, both the groups had 60%. The local side effects, the inclusion predicted side effects were 13% for IV preparation. It was the subcritical 70% for management. Higher but statistically similar. Other side effects such as diarrhea, 55, 8% patients, neutropenia, 48 patients, comparable between two groups. Minor side effects of anaphylaxis, hypersensitivity, mucositis, rate 4%, ILD, and reaction after 1%. And there is no meaningful difference in the cardiac safety between the treatment arms. Primary cardiac events were around 1 to 2% in both arms. Any secondary cardiac event that was identified by LV ejection fraction was around 4 to 5%. And this is comparable with so as we can summarize, it is not inferior in terms of kinetics. The trough concentration was inferior. So pathological response rates were 59.5%. The safety profile was comparable in both groups, and no new safety is identified in this patient. The other part of the acceptability of this molecule, two patients preferred subcutaneous preparation or child preparation. So another trial known as Metastatic phase 2 study was conducted, finding the patient preference to these preparations. Here they had patients positive early breast cancer who have preparation with pertuzumab and Herceptin in combination with chemo and surgery, and then they are now continuing the maintenance part of the treatment. So here they had IV preparation. They started for 3 cycles with IV preparation, and 3 cycles they chose subcutaneous preparation. For B, the first started with preparation initial 3 cycles to maintenance, followed by IV cycles. And the continuation period of total 18 cycles, which is the standard of care, was followed. The primary objective of this trial was patient preference for the subcutaneous preparation. The other secondary objectives like patient satisfaction, choice of preparation, health-related quality of life, healthcare professionals persist for time and each cycle, safety and tolerability, and efficacy of measures. So here, as you can clearly see, most of the patients, in 160 patients, preferred population for this treatment. 85% patients preferred the subcutaneous preparation over 16%, 14% IV arm. So it is a very strong majority of the patient, and the main reason preference was, as mentioned by the patient, was less time sitting, and that it is more comfortable during administration. And the patient satisfaction rates with subcutaneous preparation was 58% versus IV preparation was 68%. Treatment had no impact on patient healthcare time, which was comparable in both arms. Most patients had enough time to talk to their health professional during treatment. To come to the perspective of the healthcare professionals, they felt that from IV to subcutaneous did save time, and this we have seen and appreciated in our clinics also. So here, the drug preparation time from 15 to 20 minutes to reduced by 5 minutes, and in the treatment, it was used from 150 minutes to 300 minutes from that to 60 minutes. So the quickest from the start of the patient administration, and also less resource preparation and administration, and it resulted, because it comes in pre-filled syringe, it resulted in less drug wastage. Now, in this study also, adverse effect rates were compared before and after stitching, and they were found to be similar. So the most common 5 side effects they for radiation skin injury, 70% IV preparation, 7% subcutaneous. Injection site reactions. This was higher in subcutaneous preparation, around 12%. Then diarrhea, it ranged 7 to 12%. Fatigue was 5%. Hot flashes were around 6%. So So this we have mentioned, the main reason is less time increasing, more comfortable, patient satisfaction is higher, and the care also is better with the administration of this preparation. Comes to the practical concentration using this real world. This gets better over time. We have at our center also that uses this molecule, and this is ongoing. And here we have to be careful in how we train our nursing staff. So we have to make the patient sit back in a reclining chair, make them high area accessible. The person who's administering drug has to be comfortable. They have to be sitting in a chair, they sit in a position, they should be resting well. So there is no unnecessary movement during the injection. This injection site should be alternated between the left and right hand only the separate to be abnormal. The dose not be split into stitches or sides of the station. If there is slip patients, it is used. It's not able to use on one side. Each new injection should be at least 0.5 centimeters from the previous side. The area that has been held on the red group that together apart, and always have to maintain a record site where it is registered in patients. And the angle is important. It has to be at this 30-degree angle. And then patients feel any pain on the spot, and we have to ease off injection. The needle has to be in place and we have to make sure it's the right angle. If the patient does experience significant reaction or pain, it's to the pause. If the patient has serious hypersensitivity reaction, there. And as we always, as a standard clinical practice, should be medications available to treat any hypersensitivity reaction as well as there should be emergency. And the observation time is 50 minutes for looking in the living any hypersensitivity symptoms. For maintenance, it should be reduced to 50 minutes. So yes, depending on the setting, the dedicated date, there should be a for administration after observation. If it drug is administered, the chemotherapy there should be short term of plans there. For summary of this molecule, first formulation of provided antibodies in one vial or injection and officers part is the method of administration. The pharmacokinetics are comparable, response rates are comparable, and the majority of patients have this formulation in the studies. And it is now FDA and EMA approved the same medication as pertuzumab IV combination in combination with optimal IV therapy. This is my slide. Thank you very much for your time and attention.
Thank you, Dr. Videshi.
Very sorry,
It's fine. It's fine. So they can enjoy the holidays. It was a very nice presentation. I think we can compile our data from our institute and probably present that practical experience from our institute as well. I think that will be great. A nice presentation. Enjoy your holidays.
Thank you, sir.
So coming to end of the conference, I mean the CME. So to wind up the session for the last talk, I'll invite Dr. Sifali. So she'll be speaking on integrating immunotherapy into a treatment landscape for patients with TNBC. Thank you, Sifali, for making, even despite some adverse circumstances, so making for the event and then coming up for and speaking on this topic. Thank you.
Yeah, so let me share my screen. Is my voice audible?
Yeah, it is.
All right. Just one second. So is my screen visible?
No, ma'am.
Not yet.
Acha, just give me 1 second. Now?
No, ma'am.
Can I share from my side, ma'am?
Yes, please, you can. Yeah, you can share the screen, please.
1 second, ma'am, she's sharing.
Yeah. Yeah, so good evening, everyone. And I'll be talking on immune checkpoint inhibition in TNBC, the landscape of the immune checkpoint inhibitor along with various combinations. So as we know that TNBC is immunogenic tumor, and due to infiltration of tumor infiltrating lymphocytes and PD-L1 expression and various mutations. So this sets the rationale for use of immunotherapy in advanced or any other subset TNBC. Next slide, please. Yeah, next slide. So various studies and trials have tried to see till date the role of immune checkpoint inhibitor monotherapy in advanced TNBC, but I mean, to our dismal surprise that the responses have been very modest, ranging from 5 to 20%. Next slide. Yeah, so this graph again shows that though the responses in intention to treat population have been not promising, however, whatever responses occurred, they were durable kind of responses. So this led to the further initiation of the other trials looking into role of combination immune checkpoint inhibitors with chemotherapy as well as other targeted therapies. Next slide. Yeah, so though the overall response rate and PFS and OS are better in patients with various type of subsets biomarkers, people have tried to see the relation of immune checkpoint inhibitor response in terms of line of therapy use or presence of tumor infiltrating lymphocytes or the PD-L1 status. Some of the biomarkers have shown to have promising confidence to suggest a good response. However, there is no proven absolute biomarker to suggest response in association with immune checkpoint inhibitor. Next slide. Next slide. Am I audible? Next slide, please.
Yes, ma'am. Yes, ma'am.
Yeah.
Let me check.
Yes. So this trials tried to study the role of atezolizumab along with the chemotherapy backbone in first line treatment naive metastatic TNBC. The chemotherapy in the adjuvant setting was, however, permitted. So the primary endpoint to be studied was PFS and OS. Next slide. As we can see in intention to treat population, the hazard ratio was favorable, but not that impressive in favor of IO plus chemo. It was 0.80 in favor of the IO chemo arm, though it was better as compared to chemo only. Next slide. Similarly, the overall survival and in the next slide, we'll see the PFS outcomes were also better in the IO plus chemo arm. However, p-value was not favorably tested for the significance in this setting. Next slide. So though we were able to find out, okay, there is some kind of add-on treatment over and above chemotherapy in this very aggressive subset where we are looking forward to the targets and the other options of treatment. However, the results were not that impressive. Though atezo plus nab-pacli was FDA approved in metastatic TNBC in the frontline setting. Next slide, please. Yeah, so then came the IM Passion 131 study, which changed the nab-pacli backbone to paclitaxel along with the atezolizumab and versus the chemotherapy only arm. I mean, to our surprise, it was a negative study. And the reasons were not very clear why pacli could not do that much better as nab-pacli with atezolizumab could do. Next slide. Yeah, so this result I already told. Next slide. Yeah, so this forest plot is showing the same results that atezo plus pacli was not, I mean, favorably good in terms of the results as compared to the placebo plus pacli arm. Next slide. So this we have discussed. Next slide. Yeah, so then came the Keynote 355 study, and the design, it studied the Pembro plus chemo as compared to chemo in metastatic TNBC in the first line. Next slide. Yeah, so as we can see, the PFS in intention to treat population was better in the IO and chemo arm, but again, the statistical significance was not tested due to the hierarchical testing strategy. Next slide. So we can see in PDL1 CPS more than one, that is PDL1 positive patients, IO plus chemo arm did fairly well as compared to the chemo alone, with hazard ratio being 0.74. Next slide. Again, the statistical significance, however, could not reach the predefined criteria. And this slide shows that higher the PDL1 status, that is CPS more than equal to 10 population, the more impressive were the hazard ratio in favor of the IO chemo arm, that is 0.65, if favoring the immunotherapy adding. Next slide. Yeah, so this forest plot showed that in PDL1 high positive, that is CPS more than equal to 10. So Pembro plus chemo arm did fairly well in all subgroups, irrespective of the choice of chemo backbone, or say irrespective of the number of metastatic sites. Next slide. So then came this, we can discuss with the tonic study. So what did tonic studied? So it studied the immune checkpoint inhibitor maintenance after the induction chemo in basically a heavily pretreated TNBC, metastatic TNBC. The rationale was that chemotherapy given for a couple of weeks prior to the immunomaintenance could enhance the sensitivity to PD-L1 blockade. So together, the clinical and translational data of this study indicated that short-term doxorubicin and cisplatin may induce more favorable tumor microenvironment and increase the likelihood of response to the PD-L1 blockade in TNBC. However, this rationale warrants further confirmation. Next slide. So this enhancement study actually tried to see whether this chemotherapy addition to the immune checkpoint inhibitor can make another difference or not. So it studied eribulin plus immune checkpoint inhibitor and showed the favorable results in PD-L1 positive treatment naive patients in favor of the IO plus chemo arm, that is 0 prior line received. Next slide. So then this Sapphire-02 breast study, it was actually an open label phase 2 randomized trial, which aimed to see that adding a targeted treatment administered according to the identified molecular genomics of the tumor with maintenance chemo, as well as the immuno with maintenance chemo in patients without actionable mutation. And this sub-study 1 actually was the name given to the subgroup which studied the targeted therapy according to the genomic profiling as compared to the maintenance chemo. And this sub-study 2, which was named as immunotherapy study group, this studied actually in patients with no targetable mutations, whether immune checkpoint inhibitor maintenance was better than the maintenance chemo. Next slide. So though it was not a favorable study, however, the subset showed that TNBC had some benefit with addition of IO to the addition of IO maintenance to the chemotherapy arm. Next slide. Similar, next slide. Yeah. Yeah, similar results were seen in OS determination also, and it only could manage to show that TNBC had some benefit with addition of immune checkpoint inhibitor, though the number was very small to derive any conclusion. Next slide. So they tried to see the exploratory analysis that whether in TNBC subgroup did PD-L1 positivity, had some impact to have that additional benefit. And this graph, as you can see, that it shows that overall survival actually in TNBC with PD-L1 positive subgroup had a favorable outcome with hazard ratio unadjusted 0.42 with a borderline statistical significant p-value in favor of the IO maintenance arm. Next slide. Yeah, so then again, there were a couple of studies like Collet and which tried to see whether the addition of MEK inhibitor over and above the IO chemo arm could make any a statistically significant difference in the favorable outcome of the disease. Next slide. However, they could only show that there were some promising results, though may not be statistically significant at the outset. Next slide. Again, various trials tried to use AKT inhibitors like ipatasertib to see the efficacy if they can be combined with IO chemo arm, and they showed that it is quite safe to add on. Next slide. Yeah, next slide. This we have discussed. So then Topazio study, it tried to see the addition of PARP inhibitors maintenance. The adults with previously treated advanced or metastatic TNBC with recurrent ovarian, fallopian tube or primary peritoneal cancer, and dose escalation study, and it showed that niraparib addition with immunotherapy is quite safe to tolerate. Next slide. Next slide. Yeah, similarly, PARP inhibitors we have already discussed. Next slide. Yeah, next one. So I think these are the couple of studies which tried to see various permutation and combination along with the IO chemo arm and tried to find out a suitable option for treatment of this aggressive subgroup, both in the treatment naive setting as well as the post multiple line settings. Next slide. So to summarize, the immune checkpoint inhibitor monotherapy actually has a modest kind of outcomes if used in metastatic TNBC alone, and addition of chemotherapy makes a difference in the outcomes, and that is shown by nab-paclitaxel in addition with atezolizumab or any drug, be it taxanes or non-taxanes in combination with pembrolizumab in the first line setting. And we know that PD-L1 has shown to be giving us a level of confidence to add on immune checkpoint inhibitors if the PD-L1 scoring is high. And we have to understand that companion diagnostic is the way to go. We have to use the companion diagnostic test to select the choice of immunotherapy in this subset. And the trials with non-taxane backbones appear promising. That means that it is irrespective of the chemotherapy, that immune checkpoint inhibitor is making a difference, irrespective of the choice of chemotherapy rather. And various trials have tried to see whether the induction, maintenance or sequencing of another targetable agent along with the IO chemo is rather showing a difference in the overall survival or favorable outcome in that subgroup. And combination of checkpoint blockade and targeted therapies for metastatic TNBC, they look promising. However, further studies with a variable level of confidence is required to make that comment. So thank you. I rest my talk here.
Thank you, Dr. Shafali. It's an excellent talk regarding the futuristic probably approaches of TNBC. I think in the future, we probably have to do an NGS and combine various targeted agents and with IO and all that. I think it's definitely going to come. Thank you for the excellent predisposition of the talk. Thank you very much.
Thank you.
So I think with that, we come to an end of the CME here, especially concentrating on the breast and from hormone positive, HER2 negative to HER2 positive to triple negative breast cancer. So I would like to thank all my speakers for devoting the time in the evening and delivering the greatest talk. And I'll also thank Healthy Blossom for arranging and to arrange on excellent speakers for the evening and then making the event successful. Thank you for all attendees. Thank you, everyone.
Thank you, sir. Thank you all faculty, doctors. Thank you, everyone.
Yeah, we close the session. Thank you very much.
Thank you. Can you please close the meeting?